tell us that this is a bad thing to do. I'm going to address the issue by basically showing you what we've done at SEMS, just our experience. So these are my disclosures. Again, describing our experience with minimally invasive TLIF, and the data is going to come from our quality outcomes registry at SEMS, which I'll share with you. So we queried our database from 2012 to present for all minimally invasive TLIFs, and looked through the database not only at whether or not they were done, of course, but all the demographics, the proms, complications, readmissions, reoperations, and follow-up. Try to get a comprehensive picture of whether or not this is actually working well. Exclusion criteria, at least for this, were the patients who had incomplete registry data. And the standard proms are listed there, things that you guys all know about. So in our ASC, we're down in the fat belt. So we'll take someone up to a BMI of 50, believe it or not. I know, it's unbelievable, but it's true. Or weight greater than 350. And it's one of the interesting things about those of you who are facile with tubes, it's actually easier to do a fat person through a tube than it is open. Much easier. Cardiac disease not cleared as low risk. ASA 3B or above. Family history of malignant hypothermia, even though we were prepared to deal with that should it occur. And inability to ambulate. We want these patients to be able to go home. So again, queried the database for all the MI TLIFs done within our ASC, and here I am backing up. So we identified 315 patients, so fair number. Of those, 130 had complete registry data, and I'll go into why. Age ranged 20 to 72, so some youngsters, some oldsters, slightly more females than males, mainly ASA2, some 1s, some 3s. Median length of surgery, 174 minutes, median EVL, 50 cc's. And our volume has built over the years now. We do well over 100 minimally invasive TLIFs a year in our ASC currently. So it's pretty routine operation, at least a couple per week. And there are half a dozen of us at the clinic who do that operation in the ASC. Interestingly, it's one of the things I've noted about MI TLIF over the years. No one who does not do MI TLIF in my practice dares do them in the ASC. They know they won't get them out. So the open TLIF guys all take their patients to the hospital. So I don't know how many people in the room were in the QOD database, but in the early years of QOD, only the first couple of patients in any practice were enrolled. This was just the system where it was getting started up, so you'd miss patients later in the week. And then in our center, over COVID, we lost, unfortunately, a couple of our registry folks, our data coordinators. And I made the command decision, I run the group, to say, I want to keep the data on the people we've been following for years. I don't want to lose that long-term follow-up data. So we actually suspended enrollment of new patients for about a year and a half until we could recruit some additional coordinators, then ramp that back up. So again, the demographics, male-female ratio, and ASC or ASA rating, and the blood loss stuff here. Outcomes, as you would anticipate for a TLIF done anywhere, right? Especially single-level TLIF. Back pain goes from 7 to about 2.7 at 2 years. Leg VAS from 6.5 down to 2. ODI from 44 to 13, EQ5D from 0.5 to 0.8. So good, consistently good patient-reported outcomes. Good return to work and good patient satisfaction. But here's the crux of the matter. Are we sending all kinds of patients to the hospital? Are we having disasters with this? And the answer is no. So you will, if you do enough dural exposure, get the occasional durotomy. Luckily, our durotomy rate's pretty low at our institution. But one of the advantages, again, of having very little dead space is this is actually pretty easy to deal with. We fiber and glue them, and then we keep them down for a couple of hours and then mobilize them. 2 SSIs, 1 hematoma. Vast majority of patients discharged within a couple of hours of surgery. And like Larry said, you know, I started doing these minimally invasive TLIFs back in 2000. Like Larry came to visit to watch one. And I would never have guessed we would turn this into an outpatient surgery, but indeed it's occurred. We have the capability in our ASC to do 23-hour observation. Not all ASCs have that luxury. And so we did have a couple of patients that we watched up to that next morning and let them go out, but they met the 23-hour observation criterion. We had 1 patient transferred of these patients to the hospital. It was a patient who actually developed AFib post-op, and he was treated with cardiosim and amiodarone and discharged from the hospital the following day. We've had 6 readmissions within that 90-day period post-op. One was for a wound infection. Actually, it was superficial, treated with antibiotics. 1 patient presented for pain control. We had 1 hardware failure. This was a tulip that disengaged from a screw head. 1 patient had severe shortness of breath, came in for rule-out PE, turned out not to have a PE. And a patient came in with diverticulitis. We had 1 delayed hematoma. And so there were 2 reoperations within that 90 days, 1 for evacuation of the delayed hematoma and 1 for revision of that displaced tulip head. So how is this doable? Obviously, patient selection, as has been emphasized by each of the speakers, is key here. Setting expectations, and absolutely agree with Larry and the others who have said, look, if the patient doesn't want to be done in the ASC, you don't do it in the ASC. You know, that's already a red flag. We're probably not going to get that patient home, right? And early mobilizations, this, you know, it's interesting. In my experience, when patients have pain after these surgeries, it's almost always muscle spasm, right? It's the muscles that hurt. The bone doesn't hurt that much, right? And so how often do the nurses in your hospitals get patients up and out of the bed shortly after surgery? At our place, hardly ever. It's a problem. In our ASC, you know, they're coming into our pre-op area. Well, that's their post-op area too. The family gets to wait for them there. You know, we don't have a recovery room. So they come right back to their same room. One-on-one nursing. Our nurses are trained to get them up as soon as they start to wake up and start to mobilize them. I swear that's an amazingly effective technique for giving them confidence and getting them out and controlling their pain. And then lastly, you know, with all due respect to the liposomal bupivacaine, you know, we don't spend that money. This is a concoction I actually learned from my colleagues at Campbell's Clinic, the guys doing outpatient joints. They call it joint juice. And if it works like a charm, it's cheap as can be. You know, it's pennies. The formula is 1 cc per kilogram of 0.25% marcaine with epinephrine, which is bupivacaine, 30 milligrams of Toradol, and then 1/10 of a milligram of morphine per kilogram. And we use Duramorph. And we simply liberally inject that into the paraspinous muscles up adjacent to the operative region before we close the skin. You know, the other interesting thing for us, and I'll just show this to you as an aside, it's why, you know, the entire payments system should be driving stuff to the ASCs. So as one of our many efforts, we have something we call the Center of Excellence program in conjunction with one of the big hospitals we work with. And, you know, it's a shared business venture. And we'll do patients within our ASC under this program or over in the hospital if they need to go over there or want to go over there. But just to show you, this is a bundled price, and we make money doing this.
Good morning. I'm Greg Anderson.